generally we say we like to see elevation in urine free cortisol 3 to 4 times the upper reference limit. But here in this patient, we have levels which are at best 2-fold higher. So generally, for reasons that are clear, the presentation in recurrent Cushing's, partly maybe because the patient has been sensitized to the disorder, we typically accept less stringent cutoffs. Her dexamethasone suppression test was obviously abnormal, but the urine free cortisols were not as impressive as we would generally seek for in a new diagnosis of Cushing's.
So she had actually a couple that were normal, right, or within normal range. And you kept sending tests by there's 8 of them because she was sent for more and more and more, trying to shore up the diagnosis.
Right. Well, that's not uncommon. I mean, we increasingly realize that at least 10 to 15% of any Cushing's patients are so-called periodic or cyclical Cushing's, which means they have intermittent activity of their disease. And there are 1 or 2 reports that suggest that you even have situations where at initial presentation the disease appears to be in the on state, but then when it recurs, it goes into this periodic type of behavior, and we really don't understand any of why that occurs. But certainly, I guess the message for us who diagnose these patients is if you see normal values in a patient who you are clinically suspicious they may have Cushing's, and here we had a big help because we knew that Charlie Wilson had done a prior surgery, so this patient was on a watch list, so to speak, and so we looked at her very carefully. But I think the message is do not be dissuaded by 1 or 2 normal results in a patient who you suspect clinically has Cushing's, because we all miss Cushing's from time to time. Dr. Van Hurley?
When we did the studies, a comparison of urinary hydrocorticoids and dexamethasone suppression test, which is more than a quarter of a century ago, we found that the incidence of intermittent Cushing's was 10% in the patients. So remember that if Jeffrey was a part of that study. So it's 1 in 10 that does this, and the period between these episodes is very variable, but it's usually about 6 weeks to 3 months. And the confusing thing is that if you do a dexamethasone suppression test on these patients and they are on the upswing, they have obviously no suppression. On the top, they have no suppression, and then when they are on the downswing, they suppress perfectly normal. So you can get any kind of test results. And so you have to be very suspicious about this situation of fluctuating Cushing's when you see normal values in the urinary excretion. Urinary cortisol is the same thing. So,
yeah, I mean, this was something actually which I trained in the UK with a guy called Brew Atkinson, who reported probably one of the better described series in the British Medical Journal, six patients. And as Andre says, the periodicity in these patients ranges from days to weeks to months in some cases, so it really can be a bit of a cat and mouse game. And actually, just last year at our Endocrine Society, Jay Findling and Brew Atkinson did a symposium on cyclical Cushing's, and Jay recommended that in order to capture 99% of these patients, you need to test cortisol virtually every day for a month. And that's certainly what I do in these patients, because the fellows know we send them off with an order for 20 to 30 salivary midnight cortisols, which is one of the easier ways to check this, because collecting 24-hour urine-free cortisols on a daily basis for a month is not very feasible. In the UK, we had a methodology where the patient would send a spot morning urine. It was correlated very highly with the 24-hour urinary cortisol excretion, and that was sent through the meal. I'm not sure that the meal in the UK, not a lot of the shipment of biological fluids, but we are able to ship saliva at least here in the US.
Another thing, a comment that I want to make is that if a patient like that is very astute and tells you, my disease is back, and I've had some patients like that, you always talk to them because frequently they're right on target. They know exactly what their symptomatology is
Right.
when it comes back. And at that time, if you test them, they are usually abnormal. And so I think it's important to listen to them.
Right, or photograph. Actually, one of our, I don't know if she ended up in the paper, but one of them was what was then called a Powers model. And so she had photographs of herself, and her periodicity was actually every 3 months. And she brought in pictures and said, you know, here's me, and she really looked Cushing-like. And here's me 3 months ago, and she looked like a Vogue model. And then she had pictures going further back. So sometimes, you know, just pulling out the driver's license or asking for the wedding pictures, or whatever you can get, can clue you in. But I agree, a lot of these people can tell you, it's back. I'm just weak, I can't climb the stairs anymore. You know, there's certain triggers that make them aware that this thing is coming back.
So how do you interpret salivary cortisol? Is it very sensitive, specific?
I guess I would have to make a number of comments about that. And there are some issues with salivary cortisol because if, for example, a patient has gingivitis, or they brush their teeth within 2 hours before collection of the saliva, then we're actually measuring blood cortisol, which has a 1,000-fold higher reference range than salivary cortisol. So that's an important thing to be aware of. Also, there's an issue with cigarette smoking. I've had one patient recently who was an EKG tech here at UCLA, and I brought her in for a midnight serum cortisol, and she needed, I guess, last thing before sleep to pop outside for a cigarette, and so we were actually able to collect simultaneous saliva and serum at the same time. And whereas her serum cortisol was very unremarkable, her salivary cortisol was off the charts. And so high, actually, that I called the ACL lab in Wisconsin, Milwaukee, which is the original assay that Jay Fendling and Herschel Raff developed. And they said, yes, they had seen levels that high, but later, in speaking to the patient, we determined that she had actually had a cigarette at that time. And the mechanism is believed to be some agent in the cigarette which interferes with the beta-hydroxysteroid dehydrogenase locally in the mouth, and that interferes with the interconversion of cortisol and cortisone. So you get this misleading elevated salivary cortisol. So there are a few things one needs to be aware of in collecting salivary cortisols, but they can be very helpful in conjunction with some of the other more sort of standardized tests, such as the urine-free cortisol and dexamethasone. I think the bottom line is that it's uncommon that one single test in Cushing's ever gives you the full diagnosis. You need to look repeatedly and sometimes quite extensively at these patients, particularly the periodic group, which, as we've all heard from various experiences, are a really challenging group of patients to diagnose.